Hello everyone, this part we talk about the Pathogenesis Microbiology clinical presentations of CEP. Microorganisms gain access to the lower respiratory tract in several ways. Aspiration from the oral pharynx is the most common pathway. Inhaled contaminated droplets rank second. That's why we wear masks. Sometimes hematogenous spread and contiguous spread from an infected pleural or mediastinal space can occur. Once bacteria reach the lungs, they can cause an inflammatory response that results in disease. This is best studied with Streptococcus pneumonia. It rapidly multiplies in the alveolar space, leading to local hyperemia, edema, and mobilization of neutrophils. The filling of alveoli with bacteria, red cells, and fluid leads to significant increase in weight of the lung in this early phase of consolidation. The extensive list of potential etiologic agents in CEP includes bacteria, fungi, viruses, and protozoa. Newly identified pathogens include hantaviruses, coronaviruses such as SARS, MERS, COVID-19, and CMRSA. The data shows Streptococcus pneumonia is most common. It's most useful to think of the potential causes as either typical or atypical organisms. The typical pathogens include Streptococcus pneumonia, Haemophilus influenza, Moraxella, Cartarelis, Klebsiella pneumonia. The atypical pathogens include Mycoplasma pneumonia, Chlamydia pneumonia, Legionella pneumophila, and respiratory viruses. The atypical organisms cannot be cultured on standard media, nor can they be seen on gram stain. They are intrinsically resistant to all beta-lactam agents and must be treated with macrolide, fluoroquinolone, or tetracycline. Data suggests that viruses may be responsible in up to 18% of cases in CEP. In about 10 to 15% of CEP cases, they are mixed infection. This table shows microbial causes of CEP by site of care. In outpatient, Streptococcus pneumonia, Mycoplasma pneumonia, Haemophilus influenza, Chlamydia pneumonia, respiratory viruses are common. Hospitalized patients in non-ICU compared with outpatients, Legionella is more common. Hospitalized patients in ICU, Staphylococcus aureus, gram-negative bacilli is more common. This table shows the epidemiologic factors suggesting possible causes of CEP. If there is structural lung disease, you may pay attention to the Pseudomonas aeruginosa. If the patient stays in hotel or on cruise ship in previous 2 weeks, Legionella should be considered. If the patient is exposed to birds, Chlamydia psittaci should be considered. Antimicrobial resistance, especially the emergence of multi-drug-resistant Streptococcus pneumonia, has escalated worldwide over the last 2 decades. Risk factors for drug-resistant Streptococcus pneumonia include very young age and very old age, beta-lactam, macrolide, or fluoroquinolone therapy within the previous 3 weeks, alcoholism, medical comorbidities, immunosuppressive illness, or therapy. So what's the clinical presentation? CAP can vary from indolent to fulminant in presentation and from mild to fatal in severity. The common symptoms include cough, dyspnea, chest pain, fever, but it's not specific. Cough is either non-productive or productive or mucoid, purulent, or blood-tinged sputum. If the pleural is involved, the patient may experience pleuritic chest pain. Up to 20% of patients may have gastrointestinal symptoms such as nausea, vomiting, and/or diarrhea. About the clinical signs of CAP, the general examination may show tachypnea, hypotension, or tachycardia. Inspection, you see the use of accessory muscles or respiration. Percussion shows dullness over the involved area. You can hear bronchial breathing, increased vocal resonance, or crackles. The clinical presentation may not be so obvious in the elderly, who may initially display new onset or worsening confusion and feel other manifestations. So for the elderly patients, maybe there is no fever, no cough, only changed consciousness. So that's all this part. Thank you.